Manu Dogra, and he's going to be taking the session on guardrails for safety of donor, very important session. Something about Brigadier Dogra. He's professor and head Department of Nephrology at Army Hospital Research and Referral, New Delhi. He's fellow of the American Society of Nephrology, International Society of Nephrology, and Royal College of Physicians. Is the former director of Armed Forces Organ and Tissue Transplantation Authority, in short IOTA, an examiner for DM nephrology students. So I would request Brigadier Dogra to please take over. Thank you.
Thank you for the kind introduction, ma'am. Good afternoon, everyone. My name is Manu Dogra, and I come from Army Hospital R&R. It's an active transplant center, and we do around 90 kidney transplants every year. We have a very good program, and we do a lot of disease donor transplants. Okay, so the topic given to me is guardrails for donor safety. That means we should do no harm to the patients, either medically or legally or socially. Okay, so Joseph Murray is the first person who did the transplant in South Africa way back in 70s. So he was given a Nobel Peace Prize, and he said the only remaining problem was the ethical decision concerning the removal of healthy organ from a normal person for the benefit of someone else. And he says that it is the first time in the medical history that a healthy person was to be subjected to a surgery with no benefit for himself. Okay, we all know that Transplant of Human and Organs Tissue Act came into being in 1994, and it was to provide the regulation for removal, storage, and transplantation of human organs. What about kidney donation in India? Now, India is, this aspect is very, very complex because it is driven by social ethics and demography. Now, there is intersecting legal, social, and economic factors. Most of the recipients are males. Most of the donors are females. Recipients are fathers, brothers, sons, and donors are mothers, daughters, sisters, wives. So if you see this graph, the yellow one is females, the blue one is males. You see the number of donors, females. Number of recipients, males. So it's a male dominant society for us, in which the female, she sacrifices her organ. So we should be very, very careful about it, that we have to take care of our ladies. The paradigm is shifting. I'll come to the slide later on. Now, the husbands have started donating to the wives. The father-in-laws have started donating to daughter-in-laws. So things are changing. That is because of the education. So what is an ideal kidney donor? An ideal kidney donor should be healthy, should have appropriate age. The age is more than 18 years. Should be a near related or related donor, no hypertension, no diabetes, no neurological debility, no cardiac disease, no active infection, psychologically and psychiatrically normal, no malignancy, no lung disease, should not be obese, should not have any kidney issues. And the last but the most important is voluntary consenting for donation. The donor should not be pushed into donation, which is quite common in India. The challenges in our system is there's organ shortage, there are interstate variations. Suppose I have a patient who's come from Calcutta. He has to take an NOC from Calcutta first, then he has to take an NOC from the state. So that is how the rules goes. So things are being streamlined now. The last thing is illegal trade and scams. Every 3 months you get a news in the paper that there's been a scam. So we should be very, very careful about it. Now, what are the efforts which have been taken to improve the situation? There is increased awareness, lot of campaigns, one nation, one policy, and for promoting trust by optimizing the public health systems, ensuring transparency. NOTO and SOTO are doing a phenomenal job. So we should stick to their guidelines, and we should ensure a just distribution of the organs. Suppose in my hospital, if there is a diseased donor transplant, we have 2 kidneys, we'll give 1 kidney to Noto and we'll utilize the other. 5 years before, we were utilizing both the kidneys. We were never giving a kidney because we have our own patients. Now the things are very streamlined. So what are the Indian donor issues and dilemmas? Medical and psychological, legal, and the most important is social. I'll come to it one by one. Medical issues, basically I'll be talking about the contraindications. Why, what donors should not be donating. If it's less than 18 years of age, if it's diseased donor transplant, yes, they can. Otherwise, living donor, they should not. Hypertension less than 50 years, these are the medical contraindications given by Noto. Now, there's a huge list, if you see, but amongst this, I've made 2 reds. One is diabetes mellitus with abnormal GTT. 5 years back, we were not taking diabetic donors, but now the US team, they have come up with guidelines saying that diabetic donors can be taken, and we have started taking diabetic donors and they've been doing well. Second is psychiatric conditions. Initially, psychiatric conditions was absolutely no. Now, the guidelines are the patient should be as psychologically normal, well controlled on drugs. Okay? These are the relative contraindications, medical contraindications. We might take the patients if we are able to handle them. Okay, what are the health risks of donation? Why are we so concerned? First is, we take out 1 kidney, what happens to the donor? Does the donor have a kidney health risk or a surgical risk? The kidney health risk is definitely there, but it is very, very minimal. There are many people who are born with 1 kidney. They progress through their lifetime without any issues. Same thing goes with the donors. Second is surgical risks. Surgical risks are as good as same as a normal population. Now, there are many studies which have taken place, Swedish registry, Japanese registry, US registry, in which the donors have been evaluated and donor deaths have been studied. The donor survival is better than the normal population because they take care of themselves. Okay? Now, this is the most important, psychological evaluation. Why psychological evaluation is more important? It is not being done. If you see, you all transplant coordinators, you have seen psychological counseling is not done. It should be done by a psychologist or a psychiatrist. It is not done. Psychological vulnerability is very common. There are few things, pre-donation pressures like family or emotional pressure, financial coercion. मैं तुमको पैसा दूंगा, तुम किडनी दे दो. Family relatives में ऐसा नहीं होना चाहिए. ठीक है? Post-donation challenges. If the kidney is working, everything is good. If the kidney doesn't work, so there's a lot of pressure on the donor also कि तेरी kidney खराब थी. So there are a lot of things which are going on. So donor undergoes depression, anxiety, adjustment issues, regrets. There are positive outcomes also, like improved self-esteem. But these positive outcomes are only if the kidney functions very well. That is our mentality, the Indian mentality. So why psychological evaluation is important? There is need for assessing motivation of the patient for donation, to identify the psychology or psychopathology, and to guide the donor with proper informed consent. So like I said, negative psychological aspects are the most important, like motivation, hidden motives or fears of the donor are there. Then anxiety about the surgical procedure and potential health consequences. मेरी किडनी आगे जो बची है वो चलेगी कि नहीं चलेगी, मैं बीमार हो गई तो मुझे कौन बचाएगा, मुझे किडनी कौन देगा. There are a lot of things. Emotional distress, negative emotions, and regret if the kidney does not function. Adjustment and stress. Once the person donates the kidney, there's a lot of problems in adjusting to the environment at work and with their husbands or their spouses. Psychiatric vulnerability is already there. So in Indian scenario, gender, parental relations, occupation, and educational status, they all play a significant role. Now, what are the positive psychological outcomes? Like I said, if the kidney functions well, the relations they improve, self-esteem improves, and the well-being also improves. What is the role of psychologist? We should subject the donor and recipient to psychologist interview. They motivate the patient, they detect the psychological issues, and they can be taken care of. And most important is informed consent. The psychologist tells them what is informed consent, and they go ahead with the transplant after that. So this is very important for long-term benefits. So what are psychosocial risks? Psychosocial risks are the same. Living donors have a very good quality of life. Financial risks are definitely there for that 1 month when they are post-transplant. They are not able to do their jobs, household activities, but over a period of time that also improves. What are the legal aspects? I think my talk will be repeated, or it has been repeated in the morning also. So they are all repetitive things, but it is important to ingrain in the mind. So the legal aspects are, due care has to be taken. We should be aware about potential unrelated donor, high index of suspicion for probable financial transaction. That is very important. Subtle hints about coercion into donation. Coercion into donation means push करना किसी को donation के लिए. भले ही emotional coercion होगा या फिर financial होगा. So the nephrologist, the transplant coordinator have to be very, very clear about it कि छोटे-छोटे hints भी पकड़ने हैं. छोटे-छोटे hints क्या होते हैं? Literacy of the donor. अगर illiterate donor है, he'll be coerced. Impoverished है, गरीब है, उसको करेंगे. Immigrants हैं, refugees हैं, they'll be forced into. There are a lot of rackets going on in West Bengal and other places. So these are the people who are coerced into donation. Legal aspects. The most important for coordinator is donors and recipients' brief clinical history. That has to be taken, and a family tree has to be drawn. Both separately. Donor के अलग बनवाओ, recipient के अलग बनवाओ, और फिर match करो. Informed consent, you have to ask questions. There are all the questions. When and how do you come to know about the living kidney donation? Who explained the details of transplant surgery? How was your interview process carried on? One-to-one हुआ था कि नहीं हुआ था? Have you fully understood the surgical procedure? Lot many questions. Decision-making process. Who helped you in decision-making process? Is there any disagreement with the family or with the recipient? Is your decision completely voluntary? This voluntary word is very important. Voluntary means not coerced. Okay? Psychological aspects have to be looked into, and donor rights have to be protected. Now legal surety कैसी होती है? Independent evaluation by transplant team. First the coordinator, then the nephrologist and the urologist. And answer should be yes or no. Is the donor well informed? Donor has good understanding of the entire process? Is the donor fully capable of making decision? यहाँ पे psychiatric patients और psychological aspect बहुत important है. Decision has been reached without any evidence of coercion. Donor rights have been fully protected, and the donor has a significant psychological problem. If it's got a psychological problem, it's better not to take the kidney. So what are social aspects? Social aspects are basically affected by spiritual beliefs. आप गांव में जाओगे, डोनर बोलेगा मेरा ये ऑर्गन निकाल लोगे तो अगली बार मैं उसी बिना ऑर्गन के निकलूंगी. So this kind of things have to be taken care of. Lack of general awareness and forced trust in the system. We have to explain to the donors and their relatives, and they have to explain to others. It is one-on-one process, and then it has to spread. Feeling of organ trafficking, it is always there in the mind. Societal pressures within families. Women are the primary donors in Indian scenario. So the males have to be forced into donating. Now this whole process remains very critical socially and ethically, and culture factors play a big role. Social beliefs, like I said, there is distrust and misinformation that has to be killed. Spiritual and cultural beliefs have to be, you have to get over those. Gender dynamics have to be changed. Males have to also donate. Family involvement has to be there. Both the recipients and donors' families have to be involved. Now there is a paradigm shift in India. Mother-in-laws, father-in-laws, husbands, brothers and sons are now coming out. In armed forces, it's the husbands who donate to their wives. Always remember, the lady is the pillar of the house. Uske bina zindagi nahi hai. She has to be taken care of. And best people to understand that is armed forces. The person is living in the borders, the wife is handling the kids, the family, everything. If something happens to the wife, the husband comes back, he is as a donor. So this is the kind of motivation which we require. The social issues, gender and relation. Female CKD patients, they have less donors. Donors are mostly female relatives. Husband to wife donation is very less. In armed forces, very high. Relations, female donors. Wife is taken as a ever potential donor for the husband. It should not be. पहले माँ आनी चाहिए, बहन आनी चाहिए, उसके बाद आगे जाके wife आनी चाहिए. And if unrelated, mother-in-laws and sister-in-laws are coaxed into donation, which should not be there. Now, India, the kidney donation in India or the transplant surgery in India is out of pocket. We pay, the patient pays for it. If the patient is below poverty line, then the government supports. But again, the government supports for only 1 year or maybe 2 years. Governments like Assam, they give immunosuppression lifelong. So we have to talk to the patient and the donor and the recipient about this. Now, gender disparity, if you see, first I'll show you this graph. Now, this green line is socioeconomic reasons, orange is medical and biological, and blue one is cognitive or emotional reasons. So this lies women more than men donors. Now you see, green, socioeconomic is green, most of them are blue, emotional reasons, you see. And this is studies world over. So females world over are coaxed into giving kidneys. This is the Indian scenario. The female donors are more, female recipients are less. So we have to change this. The reasons for gender disparity is there are misconceptions about transplant, financial constraints. He is a breadwinner, so I should give kidney to him. ऐसा नहीं होता. Patients are elected to receive kidney from a family member. There, in my hospital, there are patients who are registered for disease donor transplant. Donor है, लेकिन वो बाहर नहीं आ रहा है कि भाई इसको disease donor kidney मिलेगी. Even if the patient has to wait for 5 years, they are ready. And they die in 2 or 3 years because life on dialysis is bad. Family members are unwilling to donate due to gender of the recipient. I do not need to explain this. आप सबको इसके बारे में मालूम है, ठीक है? So in Indian scenarios, donor acceptance practices, I have taken 4 examples. Should a young unmarried female donate? Should the minors donate? A well-controlled psychiatric patient should donate? Or diabetic donors have to donate? I will show you the data. Young unmarried females, we usually tell them, please do not donate because you have a life ahead. You have to become a mother. You will have a baby. You have to live long. So, kidney donation by young females, is it a cause of concern? So, the young females are unmarried females, younger sister, newly married wives. Now, आप सबको ये पता होगा, kidney patient goes into a marital agreement with a lady who's poor so that he gets a kidney. So what will you do if the patient gets a donor? आज ही शादी हुई है, महीने के बाद आ जाता है कि मेरे को kidney देनी है. So what will you do? There are 2 things you have to do. First is wait for 1 year. Second thing is if they have a baby, then it becomes easy. We push them because there are people, CKD patients, they can also bear kids. So we wait for 1 year. उससे पहले हम लोग नहीं करते. Okay. So what are the? Why are we so concerned? Fetal outcomes, fetal loss, maternal outcomes. So baby को क्या होता है? Prematurity हो सकती है, low birth weight हो सकता है, fetal loss, death, miscarriage, abortion हो सकता है. Maternal outcomes, mother will have diabetes, gestational hypertension, preeclampsia, proteinuria. You always remember there are 2. Somebody calling up time again. Okay. So there are 2 aspects. One is a newly married donor who's not had baby. Other is a long marriage and you have a baby later on after the donation. Both of them are high risk. The risk has to be explained. Now, post-donation, the post-kidney donation, the issues which occur are only in young people if they bear pregnancy later on, not in the initial 5 years. So the more the time to having a baby, the more are the complications. Now pregnancy outcomes. There is one study by Ibrahim et al. Which says that the prematurity, fetal loss, both are high with ladies who have donated. Gestational diabetes, hypertension and other complications are more with ladies who have donated. But there have been a pooling of studies in which they say that there is not much difference between a kidney donor who donates kidney before the bearing a kid. Once they bear the kid, the complications are almost equal to the general population. So we have to tell the donors that pregnancy is possible. You have to take due care and the results are going to be very good. Similarly, fetal and neonatal outcomes are generally good. The probabilities of having a low birth weight baby is slightly less. Less than 37 weeks gestation is slightly less, and fetal deaths are also less in post donation pregnancies. So the absolute risk of pregnancy complications are low. We should understand that. Now minors as donor less than 18 years will say strict no. The law does not permit it. Diabetic donors, yes, we have started taking diabetic donors, but there are very stringent criteria. Age should be more than 55 years, should not be taking insulin, 2 oral antidiabetics, well controlled, HbA1c should be less than 7, no complications should be there before, and the kidneys should be absolutely pristine. We take them. And the outcome of the donors is very good. You see, these graphs have shown a 10 years outcome in India. It is almost as good as the general population. So diabetic donors with strict stringent evaluation can be taken. Psychiatric illnesses, a well-controlled illness on medications can be taken with due caution. The most important thing is donors should be able to take care of self and not dependent on caregivers, and should be able to make a decision on their own. Psychological evaluation is very important, and you should involve the psychologist as well as psychiatrist. Though there is increased risk of chronic kidney disease in patients who take lithium, but it's not a contraindication. So I'll conclude my talk. Kidney donation in India is medically, ethically, legally and socially complex issue. A stringent evaluation is required. You should keep your eyes and ears open about the financial transactions. Younger females as donor have a long-term implication on pregnancy and fetal outcomes, but they are good. Minors should be excluded from donation, and psychiatric patients can donate with stringent evaluation by the psychologist as a psychiatrist and well-controlled disease. I have finished. Any questions, please? I'll be happy to answer. ये आप कर लीजिए. या तो कुछ समझ नहीं आया या सब कुछ समझ आ गया.
Afternoon, sir. So my question is that if a son is donating, he's a healthy donor, but the mother is a diabetic, which some criteria you have, should we prefer the diabetic one or should we prefer the son? Like,
if the diabetic is fitting into the criteria, those 11 criteria which I have shown, I'll take the mother as donor because the son has to progress the life. For us, donor is more important. Recipient is also important. Donor is more important. The son has to, live the full life. So first take mother if she's fitting into it. That's why those stringent criteria are there. So we'll take the mother. Yeah. Usually the sons, I know your experience about the children given to their parents. It is very less. Because if the parents, they themselves, they say no. It is very rare. It's only we have, I think we must have done 3 or 4 transplants. That too all in the Nepali patients, where the son is donated to the father. Otherwise, we do not. We always ask a mother to come as a donor, even if she is diabetic.
Dr. Manu, I have a question. One minute. You said something about the recipient gender, and we all know the reason. So what was that?
Recipient gender?
Huh.
Breadwinners.
Oh.
They're the breadwinners. So if you see everybody's family, the males have a slightly upper hand, which should not be there. That's why I said the female is the pillar of the family. She should be taken care of, and her decision is most important. She should not be coerced either emotionally or financially.
Got it.
Good afternoon, sir. Sir, if there is a patient, patient is the male, so he has potential donor in his family, but the donor is from his in-laws. In-laws.
Okay.
So that person is also a diabetic. The donor.
The in-laws donor is diabetic.
Yeah. Yeah. Then how will we go?
And he has a donor in his own family, the near relative.
there is a potential donor.
No. You
do
give me example. See, in-laws ka to I understand.
yeah.
But what about the donor in the family? Who's the donor?
Donor is the father-in-law, but the family who can donate is his wife.
Huh. See, it's a decision of the donor recipient and their family. We are there to, we do not say ki you will not donate, you will not donate. We give them an idea. For us, we have to be medically very, very sure. So if the wife is donating to the husband, if wife is donating to the husband, it's okay for us. Father-in-law donating to son-in-law,
Son-in-law.
that's their decision. If the father-in-law is diabetic and he's fitting into the criteria, medically he can donate, but finally the decision lies with the family. We have to give them pros and cons.
Okay.
We do not take a decision ki who's going to donate, but we just give them an idea that yes, if the wife is the donor, she is emotionally attached to the husband. Father-in-law wants to donate, they can donate, no issues. Law permits it. Law permits it because it has to go to the state authorization committee. There should not be any financial interaction, this transaction in between. And if the diabetic donor is fitting into the criteria, we'll take it. Because father-in-law will definitely be more than 55 years of age. He has to have a very good controlled diabetes. He should not be having any target organ damage and should be sticking to the medications. Can donate, no issues. In my hospital, we do not do unrelated transplants. We do only related transplants. We have taken a consensus decision not to go for unrelated transplants. Yeah. We have got our own SOPs. You stick to the SOPs. I cannot refuse, but no, I have a right to say I will not take the donor in a government hospital. I am a government hospital. We do not take.
Sir, in government hospital, can we deny
Yes.
that we will not do this?
If the
unrelated
nephrologist
transplant?
is not confident in the donor recipient pair, nephrologist can say no.
No, that is a separate case. That the authorization committee is not giving approval
No,
for
no,
the
no, no.
donation.
The first step is not authorization committee. First step is the transplant team. If the transplant team feels that there is something financial transactions taking place, I got full right to say no.
That is the mandate of authorization committee, sir.
No. Every hospital has got a SOP. Standard operating procedure. We have our own standard operating procedures.
I am also working in a government hospital.
We are working in a government hospital. We've been working for so long.
No, for example, you are in a army setup.
Yes.
Army may have different set of rules, but in a state government hospital, can I say no? I will not take this transplant. I will take this
See,
transplant.
Supreme Court has said right of the doctor to say no to a patient. Is that so? The doctor can say no to a patient.
Yes,
I will
sir.
not treat. Is that possible?
And what will be the reason? What we will say why we are not taking unrelated transplant?
See, unrelated transplants usually have financial coercions. The commonest thing is there. Why should unrelated transplant be there? You tell me one thing.
No, the law is permitting it. sir.
Law is permitting, let the authorization committee, but I have to be confident. Because once something goes wrong, the first person who's pointed fingers at is the transplant team.
Because we faced this problem recently, and finally it was decided that being a government hospital, we cannot say no to any patient. If the authorization committee has given them permission for this transplant, then I am no one to comment on their commercial dealing, yes or no.
Okay, for what happens if something goes wrong and something comes up, the first person who's pointed fingers at is the transplant team. So I have full right to say no to a patient that I cannot treat you. And we stick to our SOPs.
Even we discussed this case with Noto team also,
Yes.
that our transplant team is very worried. They are very apprehensive, and district authorization committee have given permission for this case. Now, on what ground we can say that we will not take up this case?
That transplant team will have to think. But I am very clear in my hospital. We do not entertain these people. We say we do not do because our SOPs are so. You have to make SOP. Hospital has to make SOP. Even if it's a government hospital, you have to make SOP.
And this SOP is approved from which level, sir?
It's our Director General.
Director General.
We are out. And we are a state in it ourselves.
हाँ नहीं,
Yeah,
but
we are a state in ourselves. Outer is a state.
army is boss in itself, man.
No, we are a state,
don't
so
take
we
order
make
from
rules for
anyone.
ourselves.
See, I have faced a court case on this count.
Yes.
Our team had said no
And then the court said.
to an unrelated donor. The court instructed the state level authorization committee to accept the file, scrutinize it, and if found appropriate, give the approval. So the authorization committee gave approval. But we were still reluctant to touch that patient. So we said, we will not do it. So that family again went to High Court. The High Court told them, if this doctor is not willing to operate upon you, find another doctor.
That's what I was saying, sir.
So High Court is very, there is a written judgment
Yes.
that like a patient has the right to choose a doctor has the patient to choose a patient.
Precisely, sir.
A donor has the right to withdraw his consent right on the
the
OT table.
Yeah.
A doctor has the right to withdraw from that operation if he finds something amiss.
Yes. You have aired my sentiments.
There is a court judgment
Court
on
judgment
that.
there. Supreme Court is very clear on this. You have a right to say no to a patient. The court cannot force you to do the thing.
Any more questions?
So, sir, my question is, I was having a case, a very special case actually. The recipient was deaf and dumb. Okay, so he was just having his parents. Mother was diabetic and above the criteria, and father was having cardiac issues. So there was no one else from the family, but he had a wife that they had 2 years of marriage without child, and both were deaf and dumb. So how can we take that donor? Can we or can we not?
Can you please introduce yourself?
My name is Jasween. I'm transplant coordinator and I'm working in Fortis, Gurgaon.
Okay. So this is a very ethically, medically complex question for me. Does the donor and recipient understand sign language?
Yes, sir.
So they can do. Somebody has to.
Go for it.
And again, psychological evaluation has to be done. Because if the donor and recipient both are deaf and dumb, both will have psychological issues.
So,
it can be done.
sorry. So the psychological, we have to go just with the one evaluation or three, like earlier I heard
Yeah.
about 3 evaluations.
The more we have 2 evaluations with the psychiatrist. For every recipient and donor, we do 2 sessions. Do more sessions, it will be better, but not less than 2 sessions. Okay?
Thank you, sir.
Okay. Thank you, Dr.
Thank you, ma'am.
Dogra. I would request Dr. Oswal to please felicitate Dr. Manu Dogra.